Yes, I can, because we have 15 years of experience with evaluating the clinical and cost effectiveness of internet and web-based interventions for common mental disorders, such as depression, anxiety, for example, phobias or panic disorders, problem drinking and other substance use related disorders. These common mental disorders have been studied the most by robust scientific methods such as randomized controlled trials. And what we can say now is when you compare this type of interventions, both for subclinical as diagnosed patients, there's ample evidence that those interventions are clinically effective when you compare them with non-intervening. So that means you have one group who receives an intervention and the other group not. That's very important because we know from epidemiological studies that almost 1 out of 2 in Europe, patients with a depression or anxiety disorders, do not receive an intervention or treatment. So that the comparator is doing nothing. There are also studies which have investigated not the experimental conditions, so the e-intervention with face-to-face treatment, and the evidence is not so abundant for that comparison as for the non-intervening group, but what we see is that, or what we at least think, that it's effective as face-to-face interventions. Now, you need to take 2 things into account with having said so, because the majority of interventions studies which we have conducted were not based on routine care practices. So they are studies, and the patients' populations, they have light, mild, moderate, or even severe complaints and disorders. But they are not the patient population what knocks on the door from their GP or specialized mental health service. So that's a new generation of studies we need to conduct. We think it is effective, but evidence needs to prove. But the first basis of evidence is there, so it's more effective than doing nothing, and it's probably as effective as face-to-face interventions.